Welcome to the ECG webinar presentation entitled Physician Enterprise Performance Improvement Trends. I'm Kevin Forster, Principal at ECG, and I'm pleased to be your moderator for today's session. Before we introduce today's speakers, let me go over a few details about the webinar. First, as you all know, it's 60 minutes in length. We'll use the first 45 minutes or so to get through the presentation, saving about 15 minutes for questions and answers. Everyone should have a copy of the session handouts. If you were late in registering or for some reason need a copy, you can download the handout in the handout pane on your screen. Please note that attendees are participating in listen-only mode, but if you have any questions, you can use the chat pane on the toolbar to enter a question. We will be answering questions at the end and try to get to as many questions as we can. Finally, upon exiting the program today, you'll be directed to an electronic survey. We'd really appreciate your feedback. So if you can take a second to complete the survey, we would greatly appreciate it. For every completed survey, ECG will be donating to Doctors Without Borders. So without further ado, let's meet our speakers. Our first speaker is Jennifer Gingras. Jennifer has been with ECG for approximately 15 years. She's based in our Chicago office and co-leads ECG's Performance Improvement Division. She's got a long history of working with physician networks on a wide range of improvement initiatives, ranging between patient access, to clinical workflows, to compensation, to productivity improvements, and brings a wealth of knowledge to this topic. So welcome, Jennifer.
Thanks, Kevin. Happy to be here today talking about one of my favorite topics.
Our next speaker, our other speaker is Jessica Turgan. Jessica is also principal with ECG and been here approximately 15 years as well, and she's out of our DC office and along with Jennifer co-leads our Performance Improvement Division. She also works with large medical groups, physician networks, as well as faculty practice plans, and brings a tremendous amount of expertise related to not only performance improvement, but redesign, labor standards, clinical workflows, with particular emphasis on revenue cycle improvements. So happy to have you here, Jessica. Thanks for joining us.
Thanks, Kevin. Happy to discuss it today.
So as noted, today's webinar will focus on trends in physician enterprise performance and really focus on ECG's 2017 Medical Group Cost and Infrastructure Survey, which we've been doing now for the last 5 years. And this survey really, we think it's something that's unique in the market and really gets into some areas that, as far as we know, don't really exist out there in terms of the depth and detail that we go into this survey. And just for background, the survey really does focus on large multi-specialty system employed and for those in California or corporate practice of medicine states, foundation affiliated medical groups. And we look at things across a host of cost categories, staff functions and operations. And we also develop those or use those, report those in various metrics using multiple denominators in terms of RVUs or visits, encounters, etc. And we wanted to share with you today not only the results of that survey, but then a few case studies in terms of how we're seeing medical groups use the survey to improve their performance. So we'll cover both trends as well as factors to consider when you're doing a benchmarking exercise. For us, it's less about the benchmarking and more about how do you use this data to actually get real results. And that's what we're starting to see the organizations we're working with actualize this data and get real results that they can see in the bottom line. So in terms of our agenda today, we'll cover just a few items. One, as I mentioned, the trends in terms of medical group performance, and we'll go through the cost survey results. Share with you some of the applications of those results and how other medical groups are using those, and save time, obviously, for your questions at the end. So with that, I'm going to turn it over to our speakers and let them walk us through this.
Thank you, Kevin. We'll jump right in to talk about trends in medical group performance first, and then I'll flip it over to Jennifer to talk more about the survey results. As you go to slide 6, what we really see is that high-performing health systems view their medical groups and their physician relationships with even independent physician groups as really a strategic asset of their overall organization. And we find that they're really seeking to aim to manage performance and aim to manage performance in no longer that fragmented or siloed structure. And so what we find is that groups are out there, organizations are out there looking to bring together their employed physician networks, looking to join clinically integrated networks and target performance improvement as part of their overall initiative. We see this because systems are looking at the medical groups now becoming the front door of that system strategy and really being the front of the health system and bringing patients into the system. And so there are a lot of publications, there are a lot recently on the news around, okay, how am I transitioning this conglomerate of fragmented, maybe smaller practices into a high performing medical group? And we think today's information will help solidify those trends that we typically see in the market with data from our cost survey. If you go to slide 7, what we typically see is that organizations are on an evolution to that highest performing medical group or that leading medical group. And so we see that leading medical groups aim to change, design, implement, and integrate into effective models to really improve efficiency, financial performance, and physician engagement. Again, many organizations start with small, loosely aligned physician groups or parties, entities across their health system, maybe some in hospital-based space, some in private practice, and then thinking through how those groups are managing performance can usually percolate up through an organizational structure in various different structures or various different forms. And so we see that most organizations are figuring out that, to really do this well and to really pay for the investment that we're making in these ambulatory environments and these physician practices, we've really got to structure our medical groups in a different way. We've got to think about execution in a much more organized way. We've got to engage physician leadership. We've got to bring best practices related to the operational functions into the clinics, and we've got to use data to drive performance. And so when you think about what are performance expectations, you can see on slide 8, there are a lot of different places that folks start to look at to say, how do I need to improve performance? How do I need to operationalize performance within my medical group? And while there are several benchmarks out there and several relate to the overall financial performance of the physician enterprise, we find that really getting good cost data related to what these changing or these integrated medical groups look like is difficult. And so, yes, we see folks that have dived into physician compensation and productivity. Usually physicians are your largest cost driver of your medical group, and so optimizing performance in that category is often an area of which many people start to focus on. But that's one piece of the overall operational performance of a high-performing medical group. And so we see that folks are wanting to understand, well, what are my revenue drivers? What are my financial performance indicators related to not only volume, but also my rates, my revenue? How am I thinking about my expense management on a per physician basis or a per work RVU basis? We tailor these indicators and we start to talk with folks across the country saying, well, what are you using? Which surveys are you using? How are you getting this information? And it's not a consistent one-size-fits-all approach. Many folks are using multiple surveys. Many folks are using information that they have derived internally. And the question we always ask, well, how do you prioritize your decisions? How are your how's your organizational infrastructure making decisions to prioritize which operational processes you're going to target for improvement, how you're going to achieve quality and value-based performance in some of your areas, and then ultimately engage with your patients so that you are managing the patient experience in an excellent way. And so what we find is folks are saying there's so much coming at us. There's so much going on within the medical group environment. How do I prioritize usually constrained resources to drive performance. And so we're going to jump into, again, the cost survey information and how that may help you prioritize where to look at performance in an easier way. But on slide 9, wanted to first sort of ground everybody in what the typical challenges are that medical groups are facing as they think about the common challenges within an integrated health system. Many medical groups are going through challenges integrating and optimizing their performance. And so typically what we see is groups have to drive to understanding the cultural differences between medical groups and hospital systems. I know for the folks that are listening to this webinar, if you're coming from one environment or the other, there are different structures, there's different methodologies even related to billing that drive performance. And when you think about educating either the C-suite from a health systems perspective on the overall strategic asset that is your medical group, what are those drivers of performance that are meaningful? Often we tie that to transitioning from an office space to a group system culture. Not only are we talking about bringing a medical group into a health system environment, but we're often talking about that conglomerate of those silos of smaller medical groups and bringing them under one structure, one integrated group structure, and that can have a cultural be a cultural change as well. The holy grail of performance is to find and adopt consistent best practices across all of these different platforms, across all of these different access points, across all of these different provider experiences, and then be able to achieve a scale. And so what we find is that folks are usually in a process of integrating technologies, integrating operational procedures that may be different from one location to the next, and needing the time to think about if we're choosing to target these types of key performing indicators, if we're trying to achieve these types of best practices, how do we do that in an environment where we're changing technology systems, we're changing what our people do on a day-to-day basis, and we're also asking them to achieve greater patient engagement, greater patient satisfaction scores, and improve the lives of their physicians. And so what we find is that folks are transitioning through these different cultural, operational, and strategic needs. On slide 10, often what we're talking with them about is, well, how are you managing? How are you managing the data? How are you managing your efforts to improve performance? And not one size fits all. It obviously starts with a high-functioning management team, but the thought process is, when you hold this data in front of your providers, when you hold this data in front of your staff members, and you bring it to the C-suite, the first thing that groups are starting to talk about is this data accurate? Is it trustworthy? Is it going to move the market? Is it going to move our performance? How do we measure? Are we measuring the right things, or are we just measuring to measure certain indicators that are not going to be drivers of our overall strategic vision for the marketplace? We often find that folks are struggling with so much data coming out at them. Now everything we can measure lots. So much data is coming out to them. How do I pick what's actionable? How do I understand and help clinic managers truly understand what is important and how they should drive at the next new patient coming in versus looking at days in AR? How do I communicate effectively throughout the organization to make sure that there's a perspective of what's important in an effort to change performance? And so what we find is that organizations are very complex, obviously in this environment, but what they're using as tools, whether the EMR, whether it's a different type of data platform, to provide the information back out to their management teams, often does not have the applicable benchmarks to really help them target in on, we need to really look at these 2 or 3 measures to help us move the bar in performance. This is going to have, if we prioritize these measures, this is how we're really going to be able to move forward and be successful. And so we find that without a true comparison mechanism to determine effectiveness for success, and being able to compare benchmarks to similar types of groups with similar types of integration platforms with similar types of experiences, we find that using some of the benchmarks out there just aren't as meaningful, and so folks have trouble targeting performance improvements. So with that said, we want to turn it back over to Kevin to lead us through the first polling question. Kevin, can you take it from here?
Thanks, Jessica. Yeah, one of the things we're always interested in is where organizations are accessing any benchmarking data that you do access. And so first question is what are the common benchmarking tools you use to measure medical group performance? And we've put a few options here, with the first one being MGMA, second one being UHC or Vizient, Advisory Board. We know many organizations use internally or locally sourced benchmarks where they'll get together with several other groups locally. And then this last option with none of the above, looking for valid benchmarks. So I'll give folks just a few seconds to fill that out, and we'll see where things land. But this, I will say that this is one of the reasons why we had organizations reaching out to us several years ago, because many were frustrated with the level of data out there and were seeking a more complex or at least more robust survey, and hence was the start of ours. So if everyone could just finish up voting, and I'll share the results here, and then Jennifer, I'm going to hand the mic back to you in just a second. So you should see coming up on your screen the results, and this is pretty standard, I think, what we see. Just so for folks not being able to see the screen, folks did respond saying 90% of the folks are using MGMA, with a much smaller percent, approximately 20% of the groups using UHC and Vizient, 34% using Advisory Board, 24% using locally sourced or internal benchmarks, and 7% still looking for valid benchmarks out there. Obviously, people could vote for multiple, and we see that a lot of groups using multiple benchmarks or sources. Jessica, any thoughts on this before we hand it over to Jennifer?
I think this is very typical across the organization. I think folks are typically using various surveys, such as listed on this page, for obviously physician comp and production targets. We also see folks using the staffing per 10,000 work RVUs or staffing per provider to understand their staffing ratios. I think when we get into it, the other costs within the practice, it's where to find those types of costs, particularly for the larger integrated practices. That's those areas that we targeted on. But Vizient, Advisory Board, others, very realistic to have to reach out to multiple sources to make sure that there are performance indicators out there that could apply to the business.
Okay, I am going to talk a little bit more in detail about our 2017 cost and infrastructure survey. And as we move into slide 13, wanted to give a shout out to our sponsors of that. So in 2017, we partnered with Intermountain Medical Group in Salt Lake City, as well as Adventist Health System, based outside of Orlando in Florida, with actually operations across 10 states. And those were our two keynote sponsors of the survey. And as sponsors, what they did was help us craft information that they were looking for in terms of actionable results and performance data that they could use across their medical groups. They also helped us recruit other members. So for 2017, we actually had 13 health systems that participated. However, that represented about 40 medical groups. And what we mean by that is that increasingly we're seeing consolidation, obviously, in the health system arena. And that consolidation has resulted in multiple medical groups that may exist within a health system. So obviously, it's easier for everyone if we have a single medical group, but when you have a multi-state health system, you're not likely to be able to run operations from a central point. And so these 13 health systems were made up of more than 40 medical groups and about 11,000 providers. It should be noted here that we were and are continuing to target organizations with more than 400 providers. So we're targeting sort of large organizations. In that realm, we also have continued to add organizations to this survey as we've gone throughout 2017 and into 2018. What I really want to talk about as we move to slide 14 is the uniqueness of this survey. And so our sponsors and our clients really felt like the benchmarks that were out there were hard to justify. They didn't know what was always in them, and wanted to have a way to really have benchmarks that they could stand behind. And so what we did was develop a process that goes all the way to the general ledger level to do apples to apples comparisons and mapping of general ledger financial data across cost and revenue categories to make sure that we could produce really valid benchmarks. And that requires a level of effort on the part of the health system that's participating in this survey as well to work with our team to do that. Another sort of attribute here is that over the last 3 years as we've done this survey, we've focused on the non-academic side. So this, as you can see from the list, is mainly community-based health systems. We are working towards being able to incorporate the academic, the faculty practice plan side as we move forward. The other piece of this that's important to note is that we have a system that maps general ledger data and cost categories accurately. And we're able to do that in an automated fashion, typically for about 85% of the general ledger data that we get. And then there's 15% that are in these cost categories that might be, you know, overhead, purchase services, things like that. And we work with the organization to actually map those to cost categories so that we can get accurate data. So really our hypothesis here is that we could develop a set of benchmarks that is as robust as what you might see on the hospital side for owned or embedded physician practices and health systems. So let's talk a little bit about what we saw in the results for 2017 as we move into slide 15. So one of the things that we constantly get asked about is as we take on medical groups and move the ancillaries and technical revenue off of the medical group books, what does that result in? What should our investment in that physician enterprise look like? And depending on how you do the accounting from health system to health system, there really hasn't been a way to look at investment per physician or loss per physician FTE in an accurate way. And so one of the major outcomes of the survey was being able to do that. And as you can see here, when we did that in 2015, as well as our most recent survey in 2017, that's coming out at a net of about a loss of about $225,000 per physician FTE. Now that is per physician FTE. We also have benchmarks at the per provider FTE level, which would incorporate a larger denominator as you start including APCs, advanced practice clinicians, in that number. But the loss at the median is about 225, and again, that takes into account all system overhead allocations that you might see for administration, for IT, and the like. So as we delve down a little deeper, one of the things our sponsors wanted us to look at as we move to slide 16 is how does that really play out by ology or by specialty? And so we also have developed benchmarks at the specialty specific level to say, okay, I understand that all in, you know, we're running about 225 at the median, but I want to drill down into, you know, urgent care and understand how much my, you know, loss per physician should be in urgent care specifically, or I want to drill into orthopedic surgery. And so we also produce these benchmarks at the specialty level and at the ology level. You can see here that as we take the ancillaries and the technical revenue sort of out, we can disagree about that for accounting purposes, but as we take that out and move that into the health system, that creates large losses sort of when you look at it from a straight accounting perspective. And so we're not here to really sort of argue about that practice, but that's common across the clients we work with, but really to say, okay, if that's the case, what should we be managing to on an investment per physician basis? As you move to slide 17, one of the things that affects this is obviously top line revenue, right? And so our survey participants do work across a variety of states, and states have different both Medicare and commercial sort of reimbursement rates. So that is not something that we're controlling for in the survey. At the median, our survey members are coming in at about 140% of Medicare, but I can tell you that varies quite significantly by state and also by the billing structure that you have set up for your group or groups. One of the things that many of our health systems that have multiple medical groups have found valuable in this is to look at reimbursement as a percentage of Medicare across their groups internally, and realizing that, you know, depending on which of their clinics is provider-based, which of their clinics might be set up as, you know, a rural health clinic or another structure that reimburses differently, that's going to drive that reimbursement as a percentage of Medicare quite significantly. So all in, we found that the groups in the survey were at about 140% of Medicare, but it varied widely. And the reason that we are purposely not controlling for that is that what we would say is that if you're an organization that only gets 120% of Medicare, number one, we got to look at your contracts. But number two, that may be the reality for your state and your situation. And so that all that means is that you need to be more efficient from an operating standpoint in order to make sure that you have the performance that you need from a cost perspective. So as we move into slide 18, we also look at staffing, staffing per physician FTE, staffing per provider FTE, staffing per 10,000 work RVUs, and we also have it per visit. What's important here is we take each of the categories, and again, since we're going down to the general ledger level, this doesn't rely on people necessarily self-reporting FTEs in these categories. So I'll give you an example. When we talk about business operations, that is going to include your billing staff or the folks that do billing for your physician practice. Now, as we all know, many organizations outsource billing to a third-party vendor, and so that's going to show up as a cost in purchase services. Other organizations have a combined billing office that's both hospital and physician billing together. Others are going to have a dedicated sort of physician billing service. And so the point of this from the methodology standpoint of the survey is that we go down to the level of that cost to be able to allocate it appropriately to take all of that noise out of the mix and really be able to give you the benchmark on the cost and staffing side that allows you to compare to other peer organizations. A similar example may be for front office staff. You may have a call center that is supporting your appointment scheduling for your physician practice, but that may be over in a different cost center. And so we make sure in working with the organization that we map that to front office staff so that it doesn't look like you have, you know, much lower staff than someone else. And so I guess, you know, in sum, the benchmarks that you see, we purposely are sort of matching the intent of the definitions that other benchmarks like MGMA and others show, but we go down to a level of understanding the granular line item level to make sure that the benchmark's appropriate. In terms of how the staffing came out for the 2017 survey data, it's coming out at about 3.8 staff per physician FTE. Obviously, as you go to the per provider FTE level, that's going to drop. In terms of median staff per 10,000 work RVUs, that was hovering at about the six staff per 10,000 work RVUs. Again, as we move into slide 19, We also do this at the specialty level or the service line level. And so that same data cut that we've been talking about for each ology, we show here some specialty. Sometimes we want to drill into a specialty where we know that they're going to have more or less support staff just due to their model. So, you know, a specialty like eye care ophthalmology, which is running high volume on the clinic side and needs a ton of support to be able to support potentially 10-minute appointments, is going to look very different than, you know, an obvious one on the other end is hospitalists, which have basically zero staff in the outpatient arena. So what's allocated there is, you know, billing and other overhead for the medical group. And so this is important because if we want to dive into a specific specialty or service line and really look at how are they performing, we need to be able to titrate those overall medical group benchmarks to this level and say, in some of the surgical specialties, our benchmarks are going to be lower. In some of the office-based specialties, our benchmarks are going to be higher. As we move into slide 20, behind all of the staffing benchmarks, then we have detail by position type. And so as we dive into, you know, how we allocate executives and senior management information technology, we go to that line item level to be able to get, you know, benchmarks at that level. I don't know many organizations that are benchmarking per se at this position type level, but I think it helps to be able to show folks, you know, as we drill down, here's what makes up this category. And here's how we got to the 1.2 staff per physician FTE that makes this up. Make sure that, you know, all of your staff is included in here. Similarly, if we look at slide 21, the same type of breakdown for front office staff. So on the front office side, we're looking at sort of the receptionist, the medical records, secretaries, phone answering, call center, all that type of thing. And our median numbers are coming in at about 1 staff per physician FTE. Again, depending on your organization, how you deploy this, this may be dispersed out in many different areas of the operations, but we account for all that as we think about the benchmark. And then finally, I think an area that is sort of ripe for a lot of conversation as we move into slide 22 is the clinical support staff side. So one of the key themes that we see is this theme of physician burnout. And as we've introduced electronic health records and requirements for quality and a ton of measurement, physician burnout has become a huge trend. And so how do we need to think about our clinical support staff really working at the top of their licensure to take some of that burden off the physicians to reduce physician turnover? So I don't think we're quite there yet as an industry. Our numbers are coming in at about 1.3 staff per physician FTE. And we need to think about, you know, if we hire that additional, you know, medical assistant or RN, how does that really help from a throughput and from a physician burnout perspective? So that was a very quick overview of what our benchmarks are. There are many more that we have in our toolkit. At this point, we're going to start talking about really the important side is how do you really apply these results? Before I do that, I'm going to turn it over to Kevin to take us to our next polling question.
Okay, this is everyone's favorite time. You get to participate now. We would like your thoughts. We'd be curious to know where you're spending your efforts in terms of medical group performance and areas of focus internally for you all. And so we've listed a few options here on your screen. If you could just fill this out, this will help the audience also just get a feel for what we're all doing across the country. And so first option is in terms of optimization efforts, focusing on evaluating staffing. Second one is titrating the provider mix. So again, a number of APCs and versus physicians. Third one is improving revenue cycle performance. Fourth option is enhancing access and referral capture. And then finally, improving payer contracting rates. And so folks could fill that out. That would be great. And you know, one of the things we are certainly seeing is that organizations, we put these up here for a reason because we're finding that the organizations we work with are all doing some of these, and in many instances running down parallel paths as they both look at, say, something like contracting rates as well as looking at more core operations in terms of staffing and so forth. Here on your screen, you should see the results, and I'll just go through them real quickly just for folks who can't see the screen. 56% of the participants said they are looking at evaluating staffing. 24% are focusing on provider mix. A little over 50% are focusing on revenue cycle performance. The highest one, 72%, is focused on access and referral capture and managing any leakage, and then 40% on payer contracting rates. Jennifer, you work with a lot of groups on this, in particular on the access and referral capture side. Anything here surprise you or any thoughts you want to share?
I don't think it's surprising. I think that strategically a theme for the last 3 or 4 years has been access, referral capture, and stemming leakage. I think on the medical group side, the tools that we've had to measure access performance and to capture referrals have been poor. You know, we're still sort of in a world where a physician provides a referral or creates an order, and then we have a whole bunch of opportunities that we have to lose the patient because we don't have effective systems for, you know, capturing that, reaching out to the patient, or better yet, capturing that patient before they leave the facility. And so it's certainly something that an area that we're doing a ton of work in.
Great. And I'm going to hand it back over to Jessica just to clean it up with a few case studies, if you will, or talk through how organizations are using this data.
Thanks, Kevin. When we've taken out the survey results to the members of the survey, I think there's been a lot of interest in using this data to create an action plan for improvement. And so Intermountain, Adventist, and others, particularly at SSM, have all used the data and said, you know, this is similar. We understand that you have mapped us to similar sized organizations. We understand that how you've treated the survey results, and so we feel very comfortable using this type of information to really target performance. And when we use some of the other surveys, it's difficult. Are we really comparing ourselves to other integrated medical groups with significant amount of complexity, or are we truly comparing ourselves to smaller groups without the level of complexity that we may have in these larger integrated systems? And so we found that, and if you go to the next slide, we found that really similar to what you all just responded to in the polling question, folks are using this data to get down to their understanding of performance at a granular level across provider management and deployment, to target how they're going to respond to reimbursement pressures, to position their value proposition in the marketplace. If we can drive costs down, do I take a market stance in being the low-cost provider? Also using the data to be thoughtful about workforce planning. And so as we think about recruiting the next ophthalmologist, the next hospitalist, the next cardiovascular surgeon, how do we need to think about the associated expenses for that individual? Now we can use some of this data to think about how we're going to both deploy that resource in the marketplace, what the associated expenses are going to be, and then what do we look for a return? How do we think about our overall deployment plan within the marketplace and what type of return we have to generate? You often linking that back to the access indicators that Jennifer mentioned. And then obviously there's also this shift towards how do we think about a lower cost care model by utilizing APPs. And so on the next slide, on slide 27, I wanted to show you a little bit of a blended comparison. We've blinded the actual results for the individual organization. But in these are the example findings that one would get from the cost survey. You can sort of understand that from the revenue outputs and from the expense outputs, how is my cost structure compared to other health systems? In this example, the net operating revenue per physician is lower than the survey median, and so the loss was around median, and that was because while they were producing higher, patient visits were lower. So maybe In this particular case, were they producing more in the inpatient environment, and what was the impact of that? Did they not have that next new patient coming back in from an ambulatory environment, and what was the overall, how does that overall impact their strategic viewpoint of this asset? In this case, the reimbursement as a percentage of Medicare was lower than the benchmark. And so while they were producing above median production, lower reimbursement led to net revenues below the survey median. And so when you sort of are able to tick and tie the survey results for your organization and then compare it to others, one can find some meaningful targets to say, okay, I can understand where I need to now focus on performance. On slide 28, we continue with some other examples. We've found that in certain cases, overall staffing levels may be lower, but in certain categories, but business operations or ancillary operations may be higher. And so what is that driving from an overall cost per physician? We've also seen where general operating expenses are below the survey median. However, certain things in certain individual categories, because we get into it, like marketing, sometimes IT, sometimes other cost drivers, maybe building and occupancy costs, really are inflating that overall spend. And so what is the implication of that? Sometimes, let's take building or occupancy, that's something that you have to just manage through in your marketplace, but have an understanding of how that then impacts your overall cost structure will allow you to target other areas where you have to improve performance that much greater because you may be in a higher cost market. Finally, when we think about a median loss per physician, this seems to be the holy grail of which organizations are truly looking for. We find that that is something that organizations often gravitate to and then say, okay, how do I build up to a median performance per physician, a median loss or an investment per physician? How do I think about that if I'm outside of that, of what a median expectation is? How do I improve performance in specific areas to navigate, to be able to improve that specific indicator? And I think Jennifer's now going to take us through a very specific example for one of our clients about how they applied the actual survey results in their areas. Jennifer?
Thanks, Jessica. So this is interesting. This organization, sort of very large, multiple physician practices across a large geography. And their challenge, as indicated here, is variation. So there's lots of variation in staffing mix and ratios, and no real sort of, from the CFO's perspective, no real benchmark that they were managing to in terms of staffing these clinics. They didn't have volume-based benchmarking, so their current practice was having one medical assistant per clinician, regardless of volume. The staff also weren't working to their proper scope. Role clarity is lacking. That gets back to some of the top of licensure comments I made earlier. Lack of adherence to standard work. The organization, from a financial perspective, was saying the current labor cost is way too high for our volume of patients, but on the other side, clinicians were saying, we don't believe we're supported enough. We're working till 10 o'clock to get through our charts, so there's a mismatch here in terms of how hard we're working and the sort of financial results and what our physician enterprise is doing financially. And so as we look at the approach that they took on slide 30, this really goes through how we collected their data to input it into the survey and make it comparable to the survey benchmarks that we had. So we went through, identified their sources of data, QA'd it, collected it, conducted the benchmarking assessment, and then from there calculated a financial opportunity associated with what that benchmarking assessment resulted in. And we also, in that process, documented areas of high and low performing clinics because there were areas that were performing from a financial perspective much better than others, and what were some of the factors that were driving that. So if you move into slide 31, the interesting thing about what this particular organization did is that they wanted to use our ECG cost survey metrics. They wanted to blend staff FTEs per provider FTE, staff FTEs per work RVU. So having both a volume-based metric as well as having sort of a static metric across their FTEs. And then also considering both work RVUs and encounters. So considering both, the traditional measure of billing as well as an encounter-based measure that relates more to managing, a population. So they used our data to do that. The other thing that they did was they looked at their internal data across each clinic and location. And they said, we're going to also look at these ratios for each clinic and location, and we're going to create a target benchmark for our organization that combines both an external benchmark as well as an internal benchmark. So they applied weights here and created a target benchmark that had a combination of external and internal. And as we look at slide 32, what they did after that is that then they determined the variance from that target benchmark on a per clinic basis. And then in step 3, determine that total FTE opportunity that was available. So if there was a variance, of 0.5 from a particular benchmark, multiplying that times the number of provider FTEs to come up with the total FTE opportunity. So this was a very back-end sort of financial exercise that happened in Excel spreadsheets. We repeated that process for the per work RVU and the per encounter metrics to get to a total weighted opportunity. Again, this was on sort of the finance and being driven by finance and on the financial side. What they found from that on slide 33 was that essentially on the primary care side, they came out in general as more overstaffed relative to this weighted benchmark that they had developed. And on the specialty care side, they came out as sort of less than the benchmark. And so they really started focusing on primary care from the standpoint of being able to sort of titrate where they were from a cost perspective. The next part of this work is then, okay, here's the math. How do we actually get the FTEs out from a financial perspective, and at the same time work with the clinics and the staff to really get to the workflow and optimize the workflow so that each person within the staff was working at the right level of their job. And so that's the part that we're going through today. So I am going to, with a few minutes left, turn it back over to Kevin to monitor our questions.
Thanks. First of all, before I launch into the questions, thanks to both Jennifer and to Jessica for walking through this. And I would add just one comment to what Jennifer was just talking about. I think it's important, while we collect obviously a lot of these benchmarks with the help of many of you on the phone in terms of you all participating and so forth, the benchmarking is really just it's directional in nature. We think we've gone incredibly granular in this data, but we also know that in terms of working with organizations multiple times, the rubber meets the road is when we get to in the clinic setting, and as Jennifer said, really working through workflows and how could we restructure assignments, et cetera, and to look at achieving some of these opportunities. The easy part is the benchmarking, quite honestly. The harder part is obviously the execution, and that's where we spend a lot of our time these days, working with organizations to actually help them with that change management and achieve some of these results. A few questions did come in here, and I just want to make sure we address a few of them. In terms of one of the questions came up, and maybe Jennifer, you can talk about this, and that was just related to the level of detail we have at the specialty level, and do we have that in terms of both revenue per provider as well as expense per provider on a given specialty. And I think you covered this a little bit, but maybe if you want to just talk about that, because there was 2 questions that came in related to that.
Yeah, so on the specialty side, working with our sponsors, what we've done is a little bit of a roll-up to what we call a service line level. Now, I'm not talking about a service line from the standpoint of what a hospital might think of, which might include both employed and independent providers, but I'm talking about a service line to say, we may consider orthopedics, sports medicine, rehab as part of the orthopedic service line. So we've created those definitions, applied them consistently, and then all of the benchmarks that we have at the in aggregate medical group level, we also have at the specialty or ology level. So I think the answer to that is yes. Obviously, there are varying, sample sizes depending on the makeup of our participants relative to the networks that they have.
Thanks, Jennifer. Another question came in just in terms of wanting to know the level of detail that participants get in terms of the ability to, in my words, slice the data different ways and cut it different ways to look at it. And so first I'll hand it to you, Jennifer, then maybe Jessica, if you want to add anything onto it, just to talk through a little bit around the tool that folks get for participating in this and the ability to sort or query the data in different ways.
Yeah, so the tool that we give the participants is essentially a very large Excel file with the ability to drill down, like I mentioned, on every ology, every metric, and within every metric on the components that make up that metric. And so we meet with each group to sort of go over their results, and then we provide them with that level of detail so that they can take that back and look at it differently within their organization. So it's fairly robust. It's essentially all of the source data in pivot tables and things like that they can work with.
In terms of one of the questions that also came in was just looking at sample size and the N. I believe we did cover that earlier in the presentation, but there's 13 medical groups participated. I'm sorry, it's 13 organizations, but over 40 medical groups, since many of the organizations had multiple medical groups. And that level continues to, or that sample size continues to increase every year for us as folks continue to see more and more value out of this. Another question that also came in, and Jessica, I'll push this to you, and this was related to seeing that we've done the survey now for multiple years, what types of changes have we seen, or are you seeing in terms of year-over-year changes between the survey years? Is there any trends there, or is it pretty consistent how things are coming out in terms of the survey?
I think there's two major trends that we're watching, and one is on the revenue side. Does the mix of revenue obviously start to change? And the decrease in net revenue that we saw this year, is that an indicator? As folks are participating in alternative value-based payment plans, we're collecting that data, we're including it in the overall structure, but is it replacing enough of the fee-for-service revenue in totality or not? And so what we are tracking and looking at is basically within a large integrated medical group, who are the winners and who may be the losers related to some of the changes in top line revenue and rate and the implications on your rates given overall performance. So that's one major trend. I think the second trend is back to, we do see the variability in particularly within certain service lines of, for example, the staffing ratios changing as we have invested in certain staff in certain specialties, and in other staffs are probably in other situations or specialties are running lean. And so similar to many groups around the country, what do we need to invest in primary care? How do we need to maximize throughput within our surgical specialties? Sometimes we've added staff or added different types of staff in those scenarios, given the overall strategic aims of the organization. So what we're watching is that variation related to staff, and do we see that fluctuating particularly between the primary care specialties and the specialty and the surgical specialty arenas, and those types of indicators are something that we track year over year.
Thanks, Jessica. In terms of one last question, and this will probably be our final question as we're running out of time here. One of the questions was how we deal with different, I'm going to summarize this, but different, how the survey takes into account different funds flow arrangements. So those might be subsidies coming across from a health system. They might be call pay amounts coming in from other organizations or the hospital, and how those filter through to the to any of our benchmarks. And so I'm going to first hand that to Jennifer, and then Jessica, you can also comment on that if you've got any insights into that. And certainly we can also provide all of the participants, or we can follow up with more detail on that. We've got as those of you who have participated, a fairly detailed description of exactly what is included and excluded in all of the definitions. But Jennifer, any thoughts on that in terms of how we deal with different funds flow arrangements and how that comes through in terms of, or is that counted as revenue, et cetera?
So, I guess from the quote subsidy side, I mean, that's something that we're actually trying to uncover, not account for. So if there are different payments that are related to closing the gap between sort of a loss and what the actual performance is, we're excluding that information. As we think about, we're really trying to say, okay, let's take all of the professional revenue, all of the professional production, and separate that from the hospital side and make sure that we're counting apples to apples. So anything that's happening sort of on the hospital side, we work with the organization to exclude. That, of course, is more difficult in some service lines and for some organizations than others, especially when we're talking about, staff leasing arrangements and things like that may occur in HOPD space. But our team is fairly facile in sort of working through that. I mean, when I mentioned earlier that this is an investment on the part of the organization as well, we are deep in with the finance folks to be able to uncover all that with multiple review points up through the CFO levels to make sure that everyone's comfortable with how that works.
Thanks, Jennifer. I think that addresses it. We are almost at the top of the hour, so I'm going to pause here and just say thank you to all of you. We really appreciate your attendance and participation in this, and hope that you benefited from this. And obviously, you can visit our website if you need additional information on the website. We've also included contact information here for our two speakers, and feel free to reach out to them for more information, as well as our sponsor groups, both Intermountain and Adventist, in terms of any questions. One final reminder before you all go: if you do have a chance, we greatly appreciate you taking a moment to complete the survey, electronic survey, about the program today, and give us your feedback on how we can make this more meaningful for you. And as we mentioned, we will be making a donation to Doctors Without Borders for each completed survey. With that, thank you everyone for attending, and enjoy the rest of your day.